Good morning, friends. I'm Dr. Vivekanand, pediatric pulmonologist from Rainbow Children's Hospital. Today we'll be dealing about a very important topic in which we commonly see. We'll be talking about under 5 V's in children. The flow of my presentation will be like we'll have a basic introduction. Then we'll see what is V's, what is non-V's symptoms, how to classify V's, what are the common scenarios which we encounter in our common day-to-day practice, what is the current GINA guidelines, what are some asthma mimics which all of us need to know, and finally we will have a few questions from your side to clarify our doubts and which will help us to understand a little more better. So the first, how will you define under 5 wheezing? There are a lot of definitions, but the commonly accepted definition is under 5 wheezing is defined as whenever a child has 2 or more episodes with signs of reversible airway obstruction in a child more than 1 year of age. So 2 or more episodes with reversible airway obstruction in a child more than 1 year of age is defined as under 5 wheezing. 50% of children have wheeze in the first 3 years of life. Only 20% of those only experience continued wheeze, and most of them are virus triggered. It is an interplay of factors between virus triggers, genetics, and environment. So when is wheezing recurrent? When there is interplay of all these factors, genetic predisposition with viral infections with surrounding environment, all these three interplay play an important role for children to have recurrent wheezing. So now what is wheeze? It's a very simple undergraduate definition, but very important from the point of view of how parents perceive this. Wheeze is a high-pitched, continuous musical noise, often associated with prolonged expiration. The next thing is, this is an important statement from article from pediatric clinics of North America. Respiratory noises, how useful are they clinically? Wheeze is often a sign which we elicit. So it may give a lot of confusion from the aspect of the caregiver as to what is wheeze. What is wheeze for a parent might not be wheeze to us. So like the famous statement which goes, a rose is a rose. So when is a wheeze? Definitely a wheeze, and when is a wheeze not a wheeze? This is a very important statement. Parents are generally 50% of the parents are poor at labeling wheeze. This was in a cross-sectional study done in a British Medical Journal in the early 2000s. So now how to make sure that how to educate caregivers is that we can show audio and video aids might be helpful. Other things is most commonly rattle versus stridor versus wheeze. So these are the common confusion. Rattle is a sound which occurs whenever there is a lot of secretions in the airways, and stridor is whenever there is more noise, then it is usually a stridor. So the common misinterpretation among the parents are they will misinterpret a rattle or a stridor with a wheeze, and finally the diagnosis might end up turning to be something else. So with a brief description, we'll just have some important questions to ponder. The first question is it asthma? How to classify under 5 V's? Is the child an atypical wheezer? And whether do we require a controller therapy for this child? These are the 4 important questions which we ponder and which we need to know. So let us answer one by one. See, history in examination always remains foremost. So what are the symptoms which we ask? Rather, recurrent cough, which is associated with afebrile episodes, with recurrent breathlessness, with nocturnal cough, diurnal variation, which we mean by seasonal variation, associated with a viral or multiple triggers like food, emotion, exercise, activity. When these are the common symptoms which we should ask. Now, how we will tell that these children do qualify for being a Wheezer? There should be recurrent episodes. There should be afebrile episodes, personal atopy, family history of atopy. The symptoms usually will be nocturnal between 12 a.m. to 4 or 5 a.m. in the morning. There must be trigger induced or seasonal exacerbations, and there must be relief with bronchodilators. Very important statement. You will whenever consider inhaled steroids, whenever there is 1 or 2 episodes of nocturnal awakening every month which is occurring, that is 2 or 3 months, and whenever the requirement of a reliever is more than 2 days per week, which is occurring every month, then you should consider inhaled steroids. The thing we should always keep in mind on examination is you should see whether there is no stridor, whether there is any chest wall deformity, whether there is any asymmetrical signs, clubbing, cyanosis, there is significant weight loss, significant failure to thrive, which is not able to explain the Wheeze alone. Careful ENT examination and other systemic examination should be done. So we classify them as symptoms, qualifiers, quantify them, and our examination findings. So how will you classify phenotypically under 5VZ? So things change with time, evolve with time. So there are some important classifications which we need to know, and we will also look upon the current classification which has been proposed by the Global Initiative of Asthma, GINA guidelines. So there is one thing known as symptom-based classification. So what is this symptom-based classification is? The European task force, people in the Europe classified them as episodic Wheeze or multi-trigger Wheeze. So episodic Wheeze is nothing but there are discrete episodes which occurs only when there is a viral infection. Symptoms usually are less than 10 days, and usually the interval period is normal. It is usually not more than 3 episodes in a year. Multi-trigger Wheeze is when there is symptoms apart from viral trigger, that is food, emotion, exercise, activity, and there will be interval symptoms more than 3 episodes in a year. Between one episode and another episode, there will be definitely interval symptoms. So this is an easy classification as episodic and multi-trigger. They are always known as multi-trigger recurrent Wheeze. The next thing is there is one famous old classification known as the Martinez classification. See, this is a time-bound classification. Time-bound classification. What we call as transient Wheezers. That is, they wheeze before 3 years, but by 3 years of age, usually viral associated, their episodes drop, and by 4 or 5 years, it settles down. Other Wheezers are known as non-atopic Wheezers. Wheeze starts before 3 years, peaks at around 5-6 years, but there is no Wheeze beyond 6-7 years. The important category is what is called as atopic Wheezers or atopic asthma. Starts below 3 years, peaks at 5 years, and continues well and above beyond 5 years. This is called as atopic asthma. However, GINA has made very simply the classification. The current classification is, it is very similar to the episodic Wheezer and the multi-trigger Wheezer. You classify them as 3 things: Wheeze with risk factor, Wheeze without risk factor. Wheeze with risk factor is nothing but whenever there is a family history of atopy, with history of asthma in a first degree relative, with personal atopy like atopic dermatitis, food allergy or allergic rhinitis, whenever there is a parental asthma or sibling with asthma, whenever the symptoms I mean always, when I mean by symptoms, it is recurrent cough, recurrent wheeze, recurrent breathlessness. Cough, wheeze, breathlessness. This is the pattern. Symptoms are usually more than 10 days each episode, with more than 3 episodes in a year. There are triggers apart from viral infections with interval symptoms. and these children are known as Wheeze with risk factors, and they qualify for inhaler therapy. The other spectrum is episodic wheezers, which is nothing but the current GINA has classified them as symptoms which occur only with a viral trigger. They are usually less than 10 days. Symptoms are usually less than 10 days and no interval symptoms, and they outgrow symptoms. We usually treat them symptomatically with the sabalone therapy, inhaled sabalone therapy. Now we have a group of children who fall in between this spectrum. That is, the symptoms of recurrent cough, wheeze, and breathlessness occurs, but the symptoms usually are more than 10 days. Each episode is lasting more than 10 days, more than 3 episodes in a year, but there are only occasional interval symptoms. In this scenario, where we have a 50-50 case, they don't fall into an episodic wheezer or a wheeze without risk factor, or they are not entirely falling into a wheeze with risk factor category also. In such scenario, we can give a trial to see for bronchodilator and a inhaled steroid responsiveness. We have to give a trial of inhaled corticosteroid. So this is the current terminology. We classify them as Wheeze with risk factor and intermediate, and Wheeze without risk factor. So we all know airway hyperresponsiveness, airway wall inflammation, and smooth muscle hypertrophy. All these things are the common aspects in asthmatic children beyond 5 years of age. But however, the pathogenic triad in preschool wheezers are a little different. Children who have recurrent wheezing, they are found to have increased bronchial airway smooth muscle. They have the epithelial lining, below the epithelial lining, the subepithelial layer has eosinophilia. And there is basement membrane wall thickening is there. This is the pathogenetic triad of recurrent under 5 or preschool wheezers. So asthma essentially remains a clinical diagnosis. Asthma or under 5 wheeze essentially remains a clinical diagnosis. Do we really need investigations for under 5 wheeze? This is the most important question which we have. So I will be mentioning the following investigations which are only adjuncts and they are not used to diagnose asthma in children. First thing is test for allergic sensitization, otherwise known as, there are two types of tests. One is serum specific IgE blood test. It is a blood test. And another one is the commonly done allergic skin prick test. So the indications for these are, whenever you have a wheeze which is difficult to control, or whenever there is a strong history of an environmental trigger, of an allergen, or whenever there is a wheeze with allergic rhinitis which is difficult to control, we can consider an allergic sensitization. Preferably, it is used when for children beyond 3 years of age, which can be done this allergic skin prick test. Chest X-ray, when should we do? Routinely, chest X-ray is not needed. And however, when we have a diagnostic dilemma, when we think of an asthma mimic, we will do a chest X-ray. And another important, whenever a child has a severe exacerbation, when the child enters an high dependency unit or an intensive care unit, then you need to definitely have a chest X-ray. LFT, I mean by pulmonary function tests. Under 5 spirometries are increasingly being being used nowadays in all research centers. There are still validated guidelines for Indian population is still yet to come. So as of now, it remains a research tool. Finally, FeNO. What is this FeNO? FeNO is nothing what is known as fractional exchange of nitric oxide. So it is a marker of eosinophilic inflammation. Previously, for children beyond 5 years of age, to see for responsiveness to inhaled corticosteroid, whenever a child doesn't respond to inhalers, we can do a FeNO and see whether a value more than 30 parts per billion can tell us whether they are going to respond to an inhaled corticosteroid. For children less than 3 years or less than 5 years, it is developing in a big way with reference values being going to be done with a lot of undergoing a lot of studies. Essentially, it is as of now a research tool with potential. So we will get to the individual case scenarios one by one. This is a 10-month-old boy who was a 35-weeker at birth. He presented with a cough, a coryza, small minimal running nose with a low-grade fever with respiratory distress and less refusal of feeds. He has an elder sibling who had a cold at home. On examination, he had used tachypneic with Krebs and Wheeze. He had respiratory distress with hypoxia, with subcostal and minimal intercostal retractions. So this is a routine prototype case which you all encounter in practice. It's nothing but the case of viral bronchiolitis. A small note on viral bronchiolitis. So what is bronchiolitis? Bronchiolitis is nothing. First episode of Wheeze in a child less than 2 years of age associated with lower respiratory tract signs. What I mean is fever with hackles. They usually do not show significant reversibility, bronchodilator reversibility, but you can try a bronchodilator. Diagnosis is clinical, supportive, seasonal, and bronchiolitis can never be recurrent. It is the first episode in a child less than 2 years of age. However, what we should know about bronchiolitis rather is when a bronchiolitis, previously there a lot of importance was given to RSV, but non-RSV bronchiolitis, for example, children with rhinovirus C and Boca virus have, and with the background of allergen sensitization and maternal asthma and exposure to cigarette smoking, particularly with rhinovirus C, there's a lot of reports of long-term asthma in children beyond 5 to 6 years of age. So non-RSV bronchiolitis with risk factors, they can tend to be asthmatics later on in childhood. So next we will move on to the second common scenario. This is a 2-year-old child who going to a creche. He has cough and wheeze once in 3 months, which starts with a fever, cold and running nose. He has no interval symptoms. He's thriving well with no family history. The episodes all last for less than 10 days. You have a wheeze and nothing else on examination. So this is a very clear-cut case of, I think all of you would have mentioned by this now. So we have to recognize the pattern. The first pattern was a bronchiolitis. This pattern, this is called as pattern recognition. This pattern recognition is nothing but a episodic viral wheezer. He has no risk factor. So he's a viral wheezer with no risk factor. Only discrete episodes, always with a viral fever or URI, no personal history, no family history, no allergen sensitization, symptoms are less than 10 days. Now what we will give here is nothing. Your treatment plan will be but inhaled SABA 4th to 6th hourly as and when needed. And you will closely follow up the child and counsel the parents because there can be phenotype change with time. But however, there are exceptions where you have to start inhaled corticosteroids in even such children. So what are those exceptions? The exceptions are whenever you have frequent episodes, that is when there are more than 3 exacerbations requiring hospitalization in a single season, then you have to give a trial of inhaled corticosteroids for 3 months. The other scenario where you will start is episode itself is a life-threatening episode. This is the first episode with a viral trigger, but it has resulted in a viral life-threatening event, resulting in admission to an ICU. In such case, you will start an inhaled corticosteroid. So this is the pattern recognition for this scenario. So moving on to the next case. This is a 3-year-old child, a girl who has monthly episodes of recurrent cough, recurrent wheeze. So the one clue here is recurrent symptoms. Second one is each symptoms are more than 10 days. There is no specific viral trigger, but there is family history of asthma, there is exercise, multi-triggers are also present. She is an active, alert child, driving well, bilateral wheeze present. So the pattern recognition here is very, very clear. So what is the pattern recognition here is it is a multi-trigger recurrent wheezer according to the old guidelines, or else You can still hold the same here. It's a multi-trigger Wheezer or a Wheeze with a risk factor. So recurrent episodes, food, exercise, emotional trigger with interval symptoms, with the personal atopy, with the family history of atopy. All these factors make sure that we have to start an ICS. Budicort is a commonly used Indian inhaled corticosteroid. Why I am using the inhaled Indian corticosteroid is I will explain in the next few slides. You have to use for 3 months with SOS SABA whenever required. No tapering of ICS, inhaled corticosteroid, is required for children less than 5 years of age. You can stop abruptly after 3 months. Exceptions, like I mentioned previously, is when the first episode itself, that is, there is a symptom only for 1 month, but it has resulted in a life-threatening episode. The big debate is Montelukast versus inhaled corticosteroid. You can take it, for example, between our two famous Indian cricketers, Virat Kohli and Rohit Sharma. Both are excellent batsmen, but who is the better captain? So your captain needs to be aggressive. Your inhaled corticosteroid or your anti-inflammatory therapy should be very potent. So according to me, Kohli is always better captain when compared to Rohit Sharma, though on a batting scale both may be equal. So what I mentioned, what I need to convey here is inhaled corticosteroids are superior and have a greater anti-inflammatory action when compared to Montelukast. Montelukast is an inferior option for children with recurrent multi-trigger wheezing or wheeze with risk factors. So this is a very alarming statement. Now then, what is the role of Montelukast here? See, Montelukast, FDA has issued a warning, a boxed warning about the serious mental side effects of asthma on children with Montelukast therapy, and advises strictly restrict using for allergic rhinitis. You have to be particularly careful in children with hyperactivity and autistic spectrum disorders, and there are even reports of suicidal ideation in adolescent age groups. So when should we use Montelukast? Previously, we are using a lot of Montelukast in viral wheezers. Currently, there is no role of using Montelukast in viral wheezers. It is just an add-on therapy whenever it is not controlled with ICS alone. You can add on. I will mention what is add-on. It is not to be used instead of ICS therapy. And always think before you ink Montelukast. Because of this is more common probably I would accept in the Western world, but things are emerging. There are also reports of warnings issued in an Indian context as well. So we will move on to case scenario 4. We totally have 6 to 7 case scenarios. So what is this case scenario? Nothing. This is the same child whom you started on inhalers. You have started the child whom we discussed in case 3. This child has been started on inhalers. Diagnosed as a multi-trigger recurrent wheezer, is on ICS. However, the child caregiver is brought for complaints of nocturnal awakening due to cough more than twice a week. They are using a SABA more than twice a week. That means daytime symptoms are also there more than twice a week. So how will you assess a level of control? Once you send a patient back home, the first follow-up should be at 4 weeks. Why we tell 4 weeks is for the inhaled corticosteroid to exert its anti-inflammatory action. Minimum time period required is between 3 to 4 weeks. There is no use in asking the patient to come back within a week itself, because the cough or the wheeze is still not going to be under good control. So you call them for after a 4 weeks time. So how will you assess control? Just it's a 4-step questionnaire. Yes or no for these 4 questions. Daytime symptoms more than twice a week. Any night awakening due to asthma. Single nocturnal awakening is significant. Use of reliever more than twice a week. And the 4th one is any activity limitation due to asthma. If none of the questions are, all the questions are negative, it is well controlled. Half of the questions are positive, it is partly controlled. If majority of the questions are positive, then you have a poorly or an uncontrolled wheeze or an asthma. So if this child, if you take our previous child, he will fall into an uncontrolled asthma because he has 3 questions which are positive. So what should we do now? What should we do now? What is the next thing? Next step? Always take into account triggers. Inquire of the triggers which may be exacerbating his or making the symptoms uncontrolled. What are those triggers? Pets. It is found that cats are more worse than dogs. Any exercise related symptoms, any pollen is more common in the Western world, house dust mite, cockroaches, any chemical fumes which is being exposed, cold air, mist, environmental, tobacco smoke, passive, active doesn't happen in our scenario, indoor air pollution or outdoor air pollution, and stress. All these are triggers common in urban as well as in a rural area. Most important, we have generally a tendency that this cannot happen in a rural area. Smoke exposure can be in any form. This type of cooking can emanate a lot of smoke and pollution, and this can also happen in a rural area. So you have to check for the triggers first. So once you have checked for the triggers, you have to check whether the inhaler is being given correctly. The technique, I'll show a video of the technique in the last slide once I finish. You have to correct the problem. Next one is you have to educate, avoid triggers, and give time. So what and all should be taken care. You have to see whether the technique is right, whether they are adhering to our technique, whether the regimen which is being followed correctly. You have to check the kit and canister. The canister has to be, whenever now the number coding has come, whenever the red mark has come, you have to advise them to change, and the kit has to be changed yearly once or whenever it is visibly damaged. You have to always rule out triggers and comorbids. Comorbids, allergic rhinitis, food allergy, allergic conjunctivitis, and atopic dermatitis. All these things should be kept in mind. Obesity and GRD also is an important comorbid which should be addressed. The last thing is increase dose. Very, very important statement. Even some books mention as increasing the dose is a sin as an initial measure. You have to increase the dose only as the last measure when you have checked all these things and you have found that there is no issues with these things. Otherwise, you have to address this and then only increase dose as the last measure. If there is any issue with this, you have to correct this. So this is a very important slide. So, and always rule out asthma mimics. How to find out an asthma mimic is, I'll tell you in the subsequent slide. So now, what is GINA's current recommendations? How GINA classifies? The current GINA recommendations are, so there is controller therapy and reliever therapy. They have also given an alternative for a controller therapy. Option A or option B. Option A is always going to be superior. And reliever therapy, which is always going to be SABA. This reliever therapy is always going to be SOS, SABA as and when needed. So step 1 is, for example, your Wheeze without risk factors. I told in the previous slides, it is nothing but SOS, SABA. What is step 2? Step 2 is whenever there is recurrent symptoms or whenever there is multi-trigger recurrent Wheezer or Wheeze with risk factors, then it is called we have entered step 2. How will you do step 2 is low dose inhaled corticosteroid with SOS SABA. What are the other options for step 2? We'll tell you. Step 3 is whenever your child is not responding to your step 2, after ruling out your comorbids and whatever I mentioned in the previous slide, you have to double the dose of ICS. And step 4 is you have to refer, continue therapy and refer. Alternate therapies for step 1, there is no alternate therapies. Step 2, you can give intermittent ICS or leukotriene, that is Montelukast. But however, this is not going to replace your option A. It is only when you have a caregiver who is not wanting to give a regular inhaled corticosteroid, you can consider this, but it is an inferior option. Step 3, What is the alternate option? Some other might come and tell you that, hey, doctor, please, I don't want to double the dose of inhaled corticosteroid. Do you have any other alternative option? The alternative option for step 3 is you will continue low dose as in step 2, but you can add on an leukotriene. That is a montelukast. And finally, step 4 is you have to take help. You have to add definitely leukotriene and sometimes give a trial of increasing the frequency of the intermittent inhaled regular corticosteroid as well. Always take help when you are in beyond step 3. This is the current GINA 2020 guidelines, which has been published recently. Now, very important, it is very surprising to find that people in the US and in the UK have removed budesonide from their regimen. Budesonide is being used for many years in an Indian context, and we are very comfortable with that, and we still recommend to use budesonide. Starting dose is 100 microgram twice a day. However, there are some concerns long term about growth velocity. That's why they have currently for a 1 to 4, they have used, the Western world has suggested beclomethasone in an MDI or fluticasone. The low dose is 50 microgram BD or 100 microgram BD. This is per day. So 100 per day is the total low dose which is recommended. However, we don't have Indian studies showing the risk factor for long-term risk factor for budesonide. We still continue to practice budesonide, that is Budecort 100 BD as the initial low dose therapy for children in the age group of less than 5 years. This is not a table of equivalence of steroids. So these are all table of equivalence, not a table of equivalence, and it indicates the lowest dose with which we should start. We still continue to use budesonide. Now, what about the low role of LABA, long-acting beta agonist with inhaled corticosteroid? Whenever I mention LABA, it is LABA with an inhaled corticosteroid. The commonly used salmeterol with fluticasone, Seroflow it is called, or formoterol with budesonide. It is called Foracort. What is it? Less than 4 years, LABA is contraindicated because of there is poor safety profile. There have been associated with tachyphylaxis, increased utilization of the beta adrenergic receptors. Efficacy is doubtful and data is lacking. So beyond 4 years, you are justified in using LABA. Less than 4 years, LABA is contraindicated. This is the take-home message from this side. So we'll move on to the last few scenarios. So this is a 8-month-old infant who is brought with cough, wheeze, and distress. He was treated with NERVs, IV steroids. He was respiratory distress. He had bilateral wheeze. He had his central retractions were more than the subcostal retractions. He has sternal indrawing a lot. And his investigations, basic investigations were normal. His X-ray was normal. History, cough and central retractions were noted from 60 days of life. There was also some frequent vomiting issues. His birth and development is normal. So what is the warning sign here? You have to, so this is you have to find out the black sheep here. So the black sheep I mentioned here is nothing but the mimicker. So the mimicker, what are mimics? What are the clues to mimics? The clue in our case was central retractions, day 25, day 50, day 60, the symptoms have started. So these are all called as atypical wheezers. When we should consider, you have to take a history examination and you have to find for the findings. Whenever there is more noise and less cough, it is going to be an airway malformation. Point 1. When the symptoms are from very early life, consider airway malformations. If the child is going to be a very young preterm child, consider BPD sequelae. Whenever there is a sudden onset symptoms, these symptoms can never be sudden. Then you have a suspicion of a foreign body. When there is significant failure to thrive with wheeze with recurrent respiratory infection, you will consider problems of mucociliary clearance, like primary ciliary dyskinesia and cystic fibrosis. Whenever you have chronic moist cough lasting for more than 4 to 8 weeks, it is not going to be an airway problem. It is going to be a mucociliary problem or a problem of bronchitis. When you have feeding difficulty with arching, consider GERD. When you have multiple system associations, multiple systemic associations, you will consider primary immunodeficiency. Always rule out congenital heart disease. Whenever there is cyanosis clubbing, when there is clubbing, it is either congenital heart disease or a suppurative lung disease. When you have a fixed monophonic wheeze, you will consider a bronchomalacia. The polyphonic wheeze is very characteristic of a airway problem. Airway, what I mean by is a smaller or larger airway problem, bronchiolitis or a wheezer, asthmatic. Monophonic wheeze always indicates an airway anomaly. Other thing is, when you have asymmetrical signs, you will consider foreign body. Whenever you have, when the breathlessness is more than the cough, the usual pattern is cough, 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 wheeze, breathlessness. When you have only breathlessness without cough, you will consider a functional respiratory problem, habit cough. When you have upper airway disease, rule out adenotonsillitis and allergic rhinitis. So this is all the atypical wheezers. So moving back to our child, we did a bronchoscopy in him. So what did the bronchoscopy reveal? So we are entering the bypass, we are entering the supraglottic region. You see the hooded epiglottis. We are in the supraglottic region. We are going to enter the vocal cords now. We see the vocal cord abducting nicely. So the supraglottic area is normal. Epiglottis, supraglottis, cord is moving well. Now we are going to enter the subglottic and we are going to go into the trachea now. We are entering the trachea now, going to enter. So once you have entered the trachea, we have a important finding which will be seen now. So we have entered the trachea now. 1 second. So we have entered the trachea now. What we see is the anterior and posterior wall of the trachea is collapsing. The anterior and posterior wall is touching each other. Usually it should be circular, rounded. The anterior and posterior wall should not come in approximation. So this is a case of primary tracheomalacia. You see it throughout the length of the respiratory tract. That is the trachea. So this is the case of primary tracheomalacia. So this is an airway anomaly. Hope the video was clear. This is moving on to case scenario 6. So we have a 4-year-old boy who has been treated for Wheeze. He is on step 4 of the GINA guidelines. All technique, regimen, everything has been checked, but he still has poor control. What else can we do? So the American Thoracic Society recommendations are, these are all having low evidence, but when you have ruled out your trigger, comorbidities and other factors, you will always consider a fiber optic bronchoscopy, including a bronchoalveolar lavage. When there is, you have to do a 24-hour esophageal pH and a swallowing study if indicated. This is only when we are in the step 4 on double dose ICS with no response. So always before doing investigations, rule out mimics. That should always be in our mind. So when the child is in step 4, that is when you have referred, what are the other treatment options? You can consider adding leukotrienes, montelukast.